Hi, this is Dr. Anjali. Today we'll talk about skin tumors. Which of the following is associated with sun exposure? Actinic keratosis, seborrheic keratosis, sebaceous cell carcinoma, or syringoma? So the answer here is actinic keratosis. What is actinic keratosis? These are pre-malignant skin lesions which later on lead to squamous cell carcinoma. They typically occur on sun-exposed areas. Predisposing factors: the type of patient would have a fair skin, a history of either a severe sunburn or a chronic prolonged photo damage, and one more risk factor is immunocompromised status. So they look like scaly erythematous patches on the skin, which are better palpated than seen. Actinic cheilitis is one variant in which you have the same scaly patch on the lip, from the vermilion onto the lip mucosa. Treatment of actinic keratosis, the various modalities: you can use cryotherapy to freeze and it'll fall off. Immunomodulators for 5-fluorouracil or imiquimod. Photodynamic therapy is one treatment option. Even chemical peels can help exfoliate those thin lesions off, as well as cauterization or radiofrequency electric cautery removal. What is seborrheic keratosis? These are benign growths and they occur from the third decade of life. That means these are essentially degenerative changes or age-related changes of the skin. So they typically look like stuck-on brown or skin-colored patches or verrucous papules or plaques on the skin. They may vary in color from yellow to gray or dark brown. Again, this depends on your skin color. They can occur anywhere on your skin except for palm soles and the mucosa. So they're typically not pre-malignant. And one important question that you can be asked is the lesser Trellat sign. So this is a paraneoplastic sign. It's when you have eruptive seborrheic keratosis occurring all over the body suddenly, usually seen associated with a GI system carcinoma. Sebaceous cell carcinoma is typically seen in older patients, and most common location is periocular. It's usually on the upper eyelid. Okay, it may just look like a skin-colored papule or a nodule. It doesn't have many symptoms, but it is quite aggressive in nature. A question you may be asked in association with sebaceous cell carcinoma is the Moore-Torre syndrome. Syringomas are completely benign lesions, so these are just sweat duct tumors. They look like yellowish to skin-colored bumps and they occur periocular usually. They are not pre-malignant at all. So the answer in that question would be actinic keratosis. Pre-malignant skin lesions are all except Bowen's disease, actinic keratosis, discoid lupus erythematosus, and miliaria. So if you've followed all the lectures till now, you'd know Bowen's is pre-malignant, so is actinic keratosis. DLE from connective tissue disorders can rarely develop an SEC in the lesion, but you know that miliaria is not pre-malignant lesion. So we'll just review in brief. Bowen's disease is called squamous cell carcinoma in situ, or intraepidermal squamous cell carcinoma. That means simply that the malignant cells are confined to the epidermis, right? They not come down into the dermis. The risk factors for Bowen's is again sun exposure, arsenic, immunocompromised status, and HPV infection. HPV can cause Bowenoid papulosis. That's a variant of Bowen's disease, okay, on the genitalia. These are well demarcated, scaly, orangish to brown plaques. They are commonly seen either on the face or the ears and on the limbs as well. Histology, it's good to know that there's a wind-blown appearance. You may be asked this. Wind-blown appearance of the cells in the epidermis. So that means there's cytologic atypia and there's loss of polarity and full thickness dysplasia. There's a 5% chance of converting towards squamous cell carcinoma in Bowen's disease. So it has to be excised. Certain immunomodulators can also be used for treatment, so 5-fluorouracil, imiquimod as well. These are some photos of what Bowen's typically looks like. DLE, I've covered in the connective tissue disorders lecture. These are again just to show you a variety of DLE lesions in case you're shown a photo. So the first is the scaling, which is inside the auricle. The second is on the scalp of phototype 1 to 2 person, a fair person with a scalp DLE. You can see the scaly, thick scales on an erythematous base with alopecia. That's probably scarring alopecia. The third photo is that of lip involvement, DLE. Down on the left, you can see this is a patient of a darker skin type, right? So that would be from an Indian to an African skin type. In these patients, the DLE lesions, of course, look different. So both the photos at the bottom, you can see there's a hyperpigmentation at the border. That's seen more often in patients with phototype 4 onwards. So what is miliaria? It is the blockage of the sweat ducts and the resulting inflammation associated with it. So it usually occurs in a situation when there's excessive sweating and some degree of occlusion also. Example, in neonates, because they're kept for prolonged time on a surface in contact with the bed, so they'll develop miliaria on the trunk. In the hospitalized patient, because again they've not moved and there's occlusion of the skin with the surface of the bed and there's profuse sweating, and in situations of extreme humidity. So the heat rash, that is typically miliaria. So it could look red like the photo above, that's miliaria rubra, or it can just look like little tiny water bubbles, that's miliaria crystallina, seen in the photo below. Multiple sebaceous tumors are seen in Carney complex, Cowden syndrome, Gardner syndrome, or Moitor syndrome. So I mentioned just before, the answer is Moitor. So just for you to know quickly what these syndromes are. So Carney complex includes the myxoma syndromes, that's the name, and the Lamb syndromes. These are basically atrial myxomas and other tissue myxomas along with lentigenes. Cowden syndrome is a multiple hamatomatous tumor syndrome. Gardner syndrome is colorectal polyps, familial colorectal polyps with epidermoid cyst osteomas and fibromas, especially of the jaw. And this Moitor syndrome is a subset of the non-polypoid colorectal carcinoma syndromes, Lynch syndrome that is ovarian and uterine and other cancers. Sebaceous tumors are associated in this. So just some photos for you to quickly understand. Cowden syndrome, here you can see cobblestone appearance of the gingiva. This is the hamatomatous syndrome. Hamatomas basically. So warty papules on the hands and tricholemomas, that is, it's one of the sheets around the hair follicle. So it's derived from that, the tumor, tricholemoma, that's seen on the face. Okay? They're just like skin colored papules on the cheek area. This is Moitor syndrome. So you'll see sebaceous adenomas as well as sebaceous carcinomas. So again, sebaceous adenomas can just look like skin color to yellowish papules. Sebaceous carcinoma may have a little bit of ulceration or little inflammation in them as well. Which of the following is not a nevus of melanocytes? Mongolian spot, Spitz nevi, nevus of Ota, and Becker's nevus. So the answer to this is Spitz nevi. I'll explain all of these. Mongolian spot is basically a dermal melanosis. So it is the entrapment of the melanocytes when they are on their way from the neural crest to the epidermis. They get caught in the dermis in the developing embryo and they fail to reach their final destination. So these melanocytes are stuck in the dermis and this gives the bluish hue of the Mongolian spot. Okay? It's a self-resolving condition, usually by age 3 or 4. Spitz nevi is a type of benign skin tumor that resembles melanoma quite commonly. This is seen in fairer populations also. So it's an epithelioid cell nevus. Okay? The melanocytes in these tumors can be inactive or it can be active, which leads to pigmented Spitz nevi. So typically seen in children. So younger patient phototype 1 or 2, that is the fairer phototypes, and seen either on the face or the limbs. Nevus of Ota is another dermal epidermal melanocytosis. So it's a nevi with, again, a slate blue or grayish brown color because the melanocytes are in the dermis. And this may be present at birth or it may develop at adolescence. Bilateral nevus of Ota is called nevus of Hori. And nevus of Ito is a dermal melanocytic patch which is usually on the shoulder. Becker's nevus is an epidermal nevus, so the pigmentation, it's in the epidermis. Seen mostly in males, and it occurs usually around puberty because it's triggered off by testosterone. So it's usually seen as an overgrowth of the epidermis as well as the hair follicles in that area and the melanocytes as well. So you have like a hairy nevus patch usually on the shoulder. Which nevi predispose to malignant melanoma? Now this is a tricky question. Okay, the answer to this is most probably junctional. I'll explain a little bit about nevi and then malignant melanoma. Okay, so how do we classify melanocytic nevi? Melanocytic nevi means basically nests of melanocytes, okay? And they can be classified according to congenital or acquired. Congenital means present at birth. And pathologically, they can be classified according to the level of the nevus cells in the skin, right? So, congenital melanocytic nevi, common ones that you need to know based on size. So it can be small, less than 1.5 centimeter diameter, medium 1.5 to 20 centimeters in diameter, and a giant congenital melanocytic nevus, CMN, is more than 20 centimeters. So the CMN, the giant CMN, has a higher tendency to go towards malignancy. That's important to know. Other congenital nevi are Caffioli macules, nevus of Ota, and Mongolian spot. According to the level of the nevi cell, so you have junctional, dermal, compound, and combined. So junctional nevus has groups or nests of the nevus cells at the junction between epidermis and dermis, and it occurs as a flat mole. So the deeper this collection of melanocytes or nevi cells are, the more palpable the lesion becomes. Okay? So in a dermal nevus, you have the nest of nevus cells in the dermis, and so the lesion becomes palpable. It's like a papule plaque or nodule. Dermal nevi can usually be skin colored actually. They are not typically pigmented. Compound nevus is where you have nests of nevus cells both at the epidermodermal junction as well as in the dermis. So you'll have a central raised area surrounded by a flat patch. And a combined nevi will have two types of moles. So a blue nevus and a compound nevus. A blue nevus is a type of a dermal nevus in which the cells are highly pigmented. So what are the malignant potential of melanocytic nevi? So usually a person with 5 or more clinically atypical nevi would have a higher risk of them developing a melanoma. Atypical nevi features would be a size bigger than 5 millimeter diameter, irregular blurred margins, unusual shapes, varying colors within the same nevus, and flat and bumpy components. What is a dysplastic nevus? It's a specific type of an atypical nevus, and this has an increased risk of melanoma. So dysplastic nevi may be compound or junctional, okay, and they'll have nevi nests or rows along the dermoepidermal junction. You'll see that in histology. There'll be cytologic atypia, and there'll be inflammatory infiltrate in the dermis as well as increased blood vessels. So this dysplastic nevus is usually junctional. That's why we would say of all the options, a junctional nevus could possibly have the highest risk of turning towards malignant melanoma. Okay, that is my logic to this question. Again, high suspicion for malignant change in nevi. So you have to remember A, B, C, D. A is asymmetry. Okay, so it should be symmetrical. That's what indicates the benign nature, right? So any asymmetry, you should increase suspicion. Borders should be regular, so irregular borders more towards malignant changes. Color, if you have more than one color in the nevus or more than 2-3 colors, increased number of colors in the same nevi again indicates malignant change. D is diameter, so diameter more than 6 millimeters, again you have to increase the suspicion. Changes like bleeding, crusting, or itching over the nevus also, you have to increase suspicion. What is an ugly duckling nevus? When there's a nevus that looks completely different from all the other nevi. Now these are seen in fairer phototypes, because in Indian skin we typically do not have many nevi on the trunk, say. Whereas if you have a Caucasian patient, you will have easily more than 50 to 100 nevi on the back. So you'll be able to pinpoint an ugly duckling nevus, something that looks different from the rest of them. And you would usually biopsy that because those have a higher suspicion for malignant change. So another tricky question, maximum malignant potential is an epidermal, junctional, intradermal, or Becker's nevus. So we've discussed all these. Epidermal is usually not malignant. Intradermal again is usually the benign type. The Becker's nevus is not malignant. So I would choose junctional from all these. Okay? Now this is another tricky question. The maximum malignant potential seen in epidermal, junctional, dermal, or blue nevus. Now blue nevus is a type of nevus which has a higher malignancy potential, though it is dermal in nature. Okay, so vismodegib is approved for treatment in basal cell carcinoma, squamous cell carcinoma, melanoma, or adenocarcinoma metastasis in the skin. So the answer here is BCC. So I'll just tell you in brief about a few drugs, okay, for melanoma and BCC. So vismodegib targets the hedgehog pathway in BCC. The indications for this are usually in a metastatic BCC, a patient who has recurrence after surgery, and in a patient who cannot be operated. Okay, so this is the only drug I think so far for BCC that you have to remember. There are there are a few more drugs for melanoma. The most important ones are ipilimumab and pembrolizumab. So ipilimumab is a fully humanized monoclonal antibody against the cytotoxic T lymphocyte antigen 4. Okay. The indications for ipilimumab is in advanced melanoma, that's stage 3 and stage 4, and metastatic melanoma. Pembrolizumab targets the PD-1, that is the programmed cell death 1 receptor in melanoma, and indications are in someone who cannot be operated or metastatic melanoma. FDA approved drugs in the treatment of metastatic melanoma are all except MEK inhibitor trametinib, BRAF inhibitors vemurafenib and dabrafenib, immune T-cell checkpoint inhibitor ipilimumab, and capecitabine. So the answer here is capecitabine. This is used in other solid tumor carcinomas. So these are just some photos of types of melanoma. Superficial spreading melanoma is usually the most common type. Okay? Nodular melanomas can look skin colored as well. They don't have to always have pigmentation in them. This is actually a nail melanoma, last photo. And acral melanoma is usually on the sole of the foot, okay, in Asian darker phototypes. Okay, so these medications, drugs that they've talked about are usually the adjuvant therapies for melanoma. So adjuvant means given after the first line therapy, which is surgical excision. So there are two types. One is the targeted therapies that blocks the MAP kinase pathway. So there are two. There's the BRAF inhibitors, the vemurafenib and dabrafenib, and the MEK inhibitors, the trametinib. Okay. Immunotherapy, there is the CTLA-4 antibody, ipilimumab, and the PD-1 antibody, pembrolizumab and nivolumab. All of the following are pre-malignant except, so this should be easy by now, actinic solar keratosis, same as actinic keratosis, Bowen's disease, pre-malignant, Bowen-oyed papillosis, a variant of Bowen's disease caused by HPV, and rhinophyma, which is not pre-malignant. Okay. So these are pictures of Bowen-oyed papillosis. On the left you see there's over the vulva, you can see these brownish to skin colored small papules, and down there you can see that's on the penis. On the right you see another pre-malignant lesion, so just giving you one more name, erythroplasia of Kierat. It's erythematous sort of scaly plaque which will occur typically on the glands. of the penis. Okay? Rhinophyma is not pre-malignant. It's basically the phymatous change which occurs in rosacea, typically seen on the nose, though it can even occur on the forehead, on the eyelids, and on the cheek, right? So this is basically sebaceous gland hyperplasia with increased blood vessels, telangiectasia, so you have that appearance, the bulbous nose. Adenoma sebaceum is characteristic of tuberous sclerosis, neurofibromatosis, incontinentia pigmenti, or lipoid proteinosis. This is an easy one, tuberous sclerosis. So here are some stigmata, maybe you can call, of tuberous sclerosis. The ash leaf marks or the hypopigmented macules or patches. These are also known as the coast of Maine. The outline is known as the coast of Maine because they're quite jagged. Okay, whereas the coast of California patches are the patches in neurofibromatosis, hypopigmented patches, the ash leaf macules. Okay. Angiofibromas in tuberous sclerosis are typically seen here over the malar surface. So these are angiokeratomas, angiofibromas, right? Adenoma sebaceum. Periungual fibromas are seen here, just coming out from the nail fold. Okay, they can be seen in the feet or the fingers. And this is shagreen patch, which is just a smooth muscle. It's basically a connective tissue hematoma. Yeah, and this is on the trunk. Okay, it's just a soft plaques basically in that dermatomal fashion. These lesions develop over 1 to 2 years. What is the diagnosis? This is quite straightforward. It's the seborrheic keratosis, multiple seborrheic keratosis over the trunk. Important to remember, lesser Trallat sign, right, in which there's eruptive seborrheic keratosis associated with adenocarcinoma colon or stomach. True about acanthosis nigricans is seen in the axilla, associated with insulin resistance, signifies internal malignancy, or all of the above. The answer is all of the above. So you know acanthosis is seen in the axilla, also in the neck folds, even in the groin folds, cubital and popliteal fossa as well. Insulin resistance, of course, is seen in acanthosis nigricans. Internal malignancy. So you can see acanthosis nigricans along with another feature. It's called tripalms. That's with the sort of velvety appearance of the palms as well. Typically seen as a sort of a paraneoplastic syndrome in GIT carcinomas, so esophageal stomach carcinoma. Okay, which is not true about mycosis fungoides. It is the most common form of cutaneous lymphoma. Portreous microabscesses, indolent course and good prognosis, and erythroderma, and spreads to peripheral circulation. This is a bit tricky question, but if we rule out all the points that are in favor of mycosis fungoides, we are left with one. So it is the most common form of cutaneous lymphoma. Okay, Portreous microabscess is a characteristic feature on histopathology in MF. And MF with erythroderma and spreading to peripheral circulation is called Sézary syndrome. So that leaves us with indolent course and good prognosis. So that would be the most appropriate answer. Okay. Though most cases again in MF can be picked up at early stages and may have an indolent course and may have a good prognosis. So of all these points, this is the most appropriate answer. So what is mycosis fungoides or MF? It's the commonest type of primary cutaneous T-cell lymphoma. It's a form of NHL, non-Hodgkin lymphoma. You can see a progression over years. So over time, you will have patch stage, then a plaque stage, and then tumor stage. And on histopathology, you have epidermotropism. So that is infiltrates of these T cells in the epidermis from the dermis. Median age is 55 to 60, male more common than female. And the clinical features, as I said, it progresses from patch to plaque to tumor. It may present very commonly as a patient with chronic itch or just scaly patches. So initially this patch stage, there may be scaling, maybe atrophic skin patches, maybe hypopigmentation, or you may even have poikiloderma. Poikiloderma is basically three components: hypopigmentation of the skin, skin atrophy, and prominent telangiectasia. Okay, so that is poikiloderma. And then you may have violaceous to brown or skin colored plaques on the skin, and then these progress to tumors on the skin. There's a variant, so there are two variants. One is erythrodermic MF. Erythroderma means when there is more than 90% of body surface area involved. And a Sézary syndrome is a type of erythrodermic MF in which you see Sézary cells in circulation. That is the atypical cells. Investigations for MF would be a skin biopsy, of course, and you may need multiple skin biopsies done over time because initially, even histopathologically, this condition can be quite confusing. You may just see lichenoid infiltrate initially, so it takes time sometimes to recognize the disease. Immunohistochemistry on the skin biopsies would also definitely be helpful. T-cell receptor gene studies. And when MF is extracutaneous, then you need some blood tests, lymph node biopsies as well, CT scans for staging of the disease. So on histopathology, there's malignant T-cell infiltrates in the dermis. These T-cells have this typical cerebriform nuclei. Epidermotropism is an important feature. That means the migration of these cells into the epidermis, these T cells. And Portier's microabscess is again characteristic. Intraepidermal collections of these atypical T cells. So I'll show you a few histopath photos. This is the patch stage in which you see a lichenoid infiltrate. A lichenoid is like a band-like infiltrate of T cells of lymphocytes in the dermis. All right, so you can see like a dark bluish band of those cells in the upper dermis, beneath the epidermis. Not too many epidermal changes. Now in the plaque stage is when cells tend to start migrating towards the epidermis. As you can see, there are some clefts over there in the epidermis where the cells have migrated into. Those are called Portier's microabscesses. And in a tumor stage, you'll see a very dense dermal infiltrate of these lymphocytes. Treatments can be topical for a patch stage or for localized disease. So steroids and bexarotene, which is a retinoid. UV light treatment as well. So both PUVA and UVB may help. Radiotherapy, total skin electron beam therapy depending on stage of the disease. Extracorporeal photopheresis and interferon alpha and oral bexarotene. Okay, a patient with pruritic lesion over the left shoulder showing cigarette paper atrophy, poikiloderma, and generalized lymphadenopathy. Histopathology shows CD4, Sézary, Lutzner cells. What is the dermoepidermal manifestation? So they just ask you what is the typical feature that you would find. So clinical features all pointing towards MF, and MF has Portier microabscess as the characteristic feature. Where are these other typical features seen? So owli inclusion bodies are cytomegalovirus. Dilapidated brick wall appearance is characteristic of Haley disease, and camel foot appearance of the retiridges. I've shown you before. I've shown these photos before, Haley, as well as camel foot retiridges in psoriasis vulgaris. Total skin electron irradiation is used in the treatment of mycosis fungoides. So that's a straightforward question.